Okay, good afternoon, everyone. Welcome to the AGMHI's first trial offering of a very different sort of webinar this afternoon. I want to apologize first up to those of you who are joining us from outside of South Africa. We've posted a link in the chat room to explain to you that there seems to have been a wide-scale power outage in the country at the moment. For the internet, so we aren't able to log on to devices, we aren't able to use cell phone cables, and for those that are lucky to be around, some generators or facilitated options are able to join us. So that's why we're just waiting a little to see if anyone is able to join us from South Africa specifically. But we're going to go ahead because I can see that there are people outside of our area that have thankfully joined and are able to access this. So welcome. Just a short round of introductions and some housekeeping before we get into it. For those of you who aren't aware, the African Global Mental Health Institute is basically a very active institute that spans the African diaspora, and it has 4 pillars that includes research, clinical service delivery, education and training, as well as advocacy. And our aim is really to provide innovative ways in which we can reach the African diaspora across the globe to be able to support contextually relevant, clinically important, and socially upholding kind of the field of mental health in various ways and forms. So one of the things we're trying to do as the clinical care work group is to launch a series of interactive webinars. So we're trying to not necessarily provide your usual webinar, which is a lecture and quite didactic, but actually to try and focus into what would be the clinical need and maybe facilitate questions from the audience. And so today we are very pleased to have with us a clinician on the ground to kickstart this initiative. And so how it will proceed is that there will be no slides. Our speaker today will start with an overview of her service and her expertise and background, and I will do her introduction bio shortly. How this will work is she will speak and allow us to get a bit of insight in terms of the service she provides, and as you're aware, discuss the collaborative supports, the challenges, and lessons that we can learn from across the globe. There is a Q&A option, so if you have any questions at any point, just go ahead and post it. Myself and the team from AGMHI will be facilitating that, and we will have at least 15 to 20 minutes for a Q&A for us to facilitate that. So please feel free to ask any clinical related questions or otherwise anything curious, any comments you may have. And at the end of this, we will have a recording that we can share for those who have not been able to make it due to unforeseen circumstances like the outage. But also we will have a survey that we will really appreciate if you could complete, so it gives us a sense as to whether or not this format is something you'd like to see us move forward on. So without any more time wasted, it gives me pleasure to read out to you the bio of our speaker today. I will say we're a bit biased in this because I lead the clinical work group, and my pet interest is maternal and infant mental health, education, training, clinical service delivery. So it was a natural fit for me to have met Anulika Ifezue. Sorry, Anulika, I practiced it. And she is a clinical lead for perinatal and infant mental health and Manchester University NHS Foundation Trust in the United Kingdom. She is a registered nurse, a registered health visitor with almost 20 years of experience as a health visitor and health visiting practice educator. She completed her master's degrees in community public health, nursing, and in healthcare senior leadership. She's also a senior trainer for the Brazelton Centre in the UK, delivering the NBO and the NBAS training. Her primary role, however, is the clinical lead and specialist health visitor for perinatal and infant mental health in health visiting in Manchester in the UK. She provides expert clinical leadership and support for health visiting services and across the city to develop and to deliver high quality evidence-based mental health assessments and interventions to parents and infants during the perinatal period. Her role involves collaboration with stakeholders, strategic and clinical leadership to establish, deliver, support, and evaluate sustaining and sustainable training programs for health visiting staffs and early years staff, and to develop pathways and policies to deliver effective services around perinatal and infant mental health. And finally, she's also served as a PI and co-I for 2 national level studies focused on perinatal mental health. So it's really such a pleasure for me to introduce Anulika. And Anulika, I also want to say that the term perinatal health visitor is really a very foreign concept to us, even in South Africa. So we're looking forward to listening to you. So welcome and go ahead.
Thank you very much, Anusha. Thank you so much, everyone. Thank you for inviting me. My name is Anulika Ifezue, Specialist Health Visitor and Clinical Lead for Perinatal and Infant Mental Health. And what perinatal mental health visitor simply means is a health visitor who has had additional training, additional qualification in perinatal mental health. I had to do a perinatal mental health model with the University of Salford, and quite a lot of robust training from the Institute of Health Visiting, and a different kind of perinatal mental health training to be able to support health visitors. And then the question is, who is a health visitor? A health visitor is either a midwife, a nurse, or it could be a psychiatric nurse, an adult nurse, or a pediatric nurse. But you have to go back to the university to do this 1 year health visiting public health training. And the simple role is to provide public health intervention across the board for the family. So in the United Kingdom, every baby from 28 weeks gestation to 5 years of age has a health visitor. A health visitor is a universal provision for all families with children under the age of 5 in the United Kingdom. So while we provide the public health interventions, we have quite a lot of roles when it comes to clinical practice, and then in maternal mental health, and both pediatric and infant mental health and maternal mental health. So I will start my introduction by thinking about why we are where we are in the United Kingdom. In 2019, the NHS United Kingdom launched what we call the Mental Health Long-Term Plan. And before then, there were quite a lot of gaps in the provision of mental health services, and those gaps needed to be closed. And then it was a system to provide a system-wide cross-organizational provision of sustainable mental health provision. And it had a very big, robust plan. And the plan is by 2024, additional 2 million people across the country should have access to perinatal or mental health care. Very big, robust plan. But we know that when we think about the World Health Organization Mental Health Atlas for 2014, 45% of the world population live in areas where there is only one psychiatrist per 100,000 people. One psychiatrist per 100,000 people. So when we solely rely on specialists to provide mental health care, we have this risk of leaving millions of people without care. Hence, of course, we have the Mental Health Gap Action Program, which was also developed by the World Health Organization. And the gap action is we're thinking about where are the gaps and how do we manage it? And that mental health gap then looked at provision of integrated mental health care that will look at mental health provision anywhere you find families. Anywhere you find mothers and children and fathers, there should be maternal mental health care. And that includes in the healthcare for women, maternal and child health care provision, in reproductive health, if mothers are accessing gynecologists, obstetricians, and wherever families go, there needs to be a mental health provision for them. And that also includes any other relevant services, whether they're going to the community centers to access support, whether they're going to the general practitioners. Everybody working with families should have a basic knowledge or advanced knowledge of the provision of mental health care, especially when we're working with mothers. The next thing is 1001 Critical Days Manifesto that was launched in the UK. The 1001 Critical Days Manifesto simply says that we have to think about the 1001 days of the child's life. And that is from conception to the first 2 years of life. And it's because it is a critical period when the brain of these babies, these children, are wired. Yes, we understand that there is what we call brain plasticity. The brain will continue to grow, to rewire, to regenerate. But we know that the 1001 critical days is when the foundation is laid. So while the mothers are struggling with the mental health, babies can't wait. So while the mothers are waiting to access mental health care, these babies' brains are being wired, they are growing. And we know that the quality of the caregiving the babies have in these first few years of life lays the foundation for their outcome in the future life as they grow up. So knowing and having all that, we now think about mental health then across the world. Let me step out of United Kingdom. In the developing world, mental health remains one of the leading causes of maternal death in the perinatal period. There's a recent launch of a document in the United States of America, and of course in the United Kingdom, the Embrace Report clearly states that mental health is one of the leading causes. Many years ago, if you're thinking about the Western world, you will be thinking about something like cardiac anomalies or preeclampsia. But a lot of funding is gone into the management of these physiological ill health. So these physiological ill health have a clear pathway, lots of evidence-based research, a lot of funding put into it. So it is no longer one of the leading causes of death. And then, of course, we have the mental health exceeding these ones. And of course, if we have this happening in the Western world, I'm just wondering what is happening in many parts of the world where you have fewer people trained, fewer people able to provide this care. The challenges, if we think about the United Kingdom, the challenges is the fact that we have quite a lot of diverse population. And the diverse population, a lot of people access support from wherever they have the trust built. So you have people accessing support from their religious group, from the mosque, the churches, the Buddhist temples, or wherever they feel and they have this sense of belonging. That is often where they want to go and access help and support. So we need to look at a system whereby wherever people go to, whether they go to the community centers, whether they go to the sure start centers, as we call it, or the family hubs, as we call it in United Kingdom, the people providing this care will also have a basic training and understanding mental health and the referral pathway and who is available to provide that intervention. So in the United Kingdom, apart from the fact that people access care wherever they go, you have, of course, the issue about funding is still there on the table. We have the issue about funding. We don't have limitless funding. So we have to think about sustainable healthcare that works for everyone. And then we have to think about where people are located, how far it takes them. How long does it take them to get to where they're going to get the care? And then, of course, the issue about stigma around mental health still remains a reality to many population groups. So in the United Kingdom, we have what we call the stepped care. So I'm going to be working on the mild to moderate. And in the stepped care approach, we have the step 0. And in step 0, it is where everybody working with families sit. And in step 0, it's about promoting mental health well-being. So The person doesn't have to be a mental health trained practitioner. Wherever families go to, there will be a system in place while you're offering immunization, where you're offering whatever care, you are also promoting mental well-being. So it's the responsibility of the community groups, the voluntary sector. And then we go to step one. And in step one is where we have the general practitioners, the primary care professionals that are seeing families. And then, of course, we have the health visitors in this place because we're universal provision. We see everybody. What do? We do assessment. And in the United Kingdom, there is a structured assessment of maternal mental health as part of what we do. While you're doing every other assessment, you're doing every other intervention, there is a system in place for you to assess for maternal mental health. And then, of course, there is a system in place for active monitoring. So in active monitoring, you're thinking about risks. And in the risk, we think about the amber flags and the red flags. I'm going to go to that. And then in step two is where we have the talking therapy, and it's a lower level talking therapy. You have the psychological therapy, the guided self-help, and psychoeducation. And of course, you have step three. And in step three, you now dip into moderate to severe. So I'm going to stop at step three. Above step three, you have the step four, where you have the psychiatrics, the inpatient, the acute care, and then the crisis team, the home treatment team. But for the interest of this webinar, I'm going to start from step 0 to step 3. And all this is driven by evidence, choice, sustainability, easily accessible, system-wide connection. And I just want to talk about what we call like a Thrive model. And in the Thrive model, first of all, is staying well and being well, and then getting help. I need to get more help. And now we're thinking about risk. What do we do? So for the health visitor, when we see mothers, we do an antenatal visit. And in the antenatal visit, one of the things we do is to do maternal mental health assessment using the PHQ-2 and the GAD-2 assessment tool for depression and anxiety. And depending on what the score is, we can now step forward and use what we call the Edinburgh Postnatal Depression Scale, or the PHQ-9 or the GAD-7 assessment tool. We also use clinical judgment. Every health visitor is robustly trained, and there are refresher sessions every 2 to 3 years where they come back again, and there is opportunity for us to look at our pathway, to look at the recent evidence coming up. How do we then make sure that we're integrating it? And then when we do the 6 to 8 weeks at the new birth visit, so every baby and mother should be seen by a health visitor within 10 to 14 days of the child's birth, except the child is in the special care baby unit, and in the special care baby unit, there's a different system of provision there. But in the community, once the mother comes home, we go out to see the mother within 10 to 14 days of having a baby, and there is a maternal mental health assessment in that visit. And then a 6 to 8 weeks visit, there is then what we call robust maternal mental health assessment. It has a system in place, it's monitored, there is a governance system in place, it is reported to the Department of Health. So they keep an eye on what we're doing. How many mothers had their maternal mental health assessment done? And then apart from the assessment, we have a system in place for providing what we call emotional well-being support, emotional well-being intervention. All health visitors should be trained to deliver what we call emotional well-being visit. And it's purely around managing emotions, supporting those mothers using listening, some non-directive counseling skills, to listen, to reflect back, and then to help mothers understand their feelings and their moods. And then when they're able to identify their feelings, we now go into different systems of managing it. This is from the health visitors angle. It includes psychoeducation, connecting them to the groups that run in the community, referring to the GP for medication, referring to the talking therapy so that they can access therapy. And then in the health visitors role, we will look at problem-solving skills. Because when we look at maternal mental health, there are other things that lead to maternal mental health problems, and that includes problems, issues around debt, issues around housing, issues around relationship between the mother and the baby. And we know that evidence shows that when a mother is estranged from the baby, it worsens the mental health of that mother. But when that mother has an improved relationship with that baby, it helps towards the healing for the mother. So there's a system for problem solving. There's a system for what we call stress busting strategies. How can this mother reduce the stress level? So we work with that mother to work through stress busting strategies and then self-care. And then, of course, we look at what we call happiness tasks and then building relationships between her and her baby, and between her and the relationships that she has in her life. That could include her partner, her husband, and her family all together. And then, of course, we do a lot of risk management. So risk assessment, looking at the amber flag and the red flag. And in the amber flag, we'll be looking at things like, for example, history of psychiatric illnesses. If the mother has had a previous history of psychiatric illness, that is a flag. So we have to keep an eye on that mother. If there is a family history of psychiatric illness, we have to keep an eye. And the risk that I'm talking about is the risk of suicide. And then, of course, we look at the red flags as well when we work with the mothers. And that red flag simply means there is an imminent risk of this mother doing something that is not so pleasant. And then, of course, there is a system in place and there's a pathway in place for referring these mothers to get the help that they need urgently. So when we step away from the health visitor, so the health visitor is also very quickly is a case holder for babies. Any mother, any baby that goes to see any health clinician, that health clinician will send a summary to the health visitor. So we have a record of all the babies, and that's the health record until they're 5 years. And when they're 5 years, we'll transfer this health record to the school nurse, who will continue to see them in the schools. Let me just go quickly. I talked about the stepped care. Let me think about step 2. What happens in step 2? In the step 2, the practitioners would have had maybe a degree in psychology. And we know that a degree in psychology does not equip people to just go and then deliver therapy for those who are struggling with their mental health. So in the United Kingdom, they have to go to the university to obtain a diploma or certificate in primary care mental health interventions. And they start as trainees. So when they are accessing this training in the university, they're also working with psychological well-being practitioners who are already delivering this service. And the service they deliver include what we call the cognitive behavioral therapy skills. That's what they use. They're not CBT practitioners, but they use CBT skills to deliver this care. And they also use what we call non-directive counseling, which is person-centered counseling that a lot of us will know about. So they provide this care wherever these families are. So the first thing I'll talk about is access. How do they access them? Mothers can refer themselves to psychological well-being practitioners. And then they can also be referred by health visitors or by their general practitioners, by the GP. And the mothers are allowed to bring the babies into the room during therapy. A lot of mothers previously might not have accessed this therapy if they will have to find childcare. For example, if she's a single mom, it might be difficult for her to access the therapy. So the babies are allowed to be in the room with the mothers. We also know that the evidence clearly says that when mothers are not estranged from their babies, they're more likely to recover, because the improved relationship between mothers and their babies helps to improve both the mental well-being of that baby and the mental well-being of the mother. The services are delivered at the community centers or the Sure Start centers. So the psychological well-being practitioners will go where the mothers are. They will go to the Sure Start centers. They will go to the community centers to deliver the care. So making it easy for mothers to access that care. The dads to the babies also have what we call perinatal priority pathway. These mothers, once they have babies under the age of 2, they are prioritized. And in prioritizing them, they are assessed from the time the psychological well-being practitioner receives this referral. These mothers are prioritized and triaged within 2 weeks. Within 1 to 2 weeks, they will be assessed. And the assessment is often a phone call. And then they're expected to start therapy within 4 weeks. One of the reasons we know is that the risk of deterioration is higher, and there is a baby in the house that cannot wait for the mothers to be there for many years and for many months to access care. And then there's a lot of ways to access psychological well-being therapy. It can be over the video, it can be by phone call, and it can be face-to-face, and it can be e-therapy, like an online CBT therapy where mothers can access it through the online, and it's already built in the system. They are given access to it, and they can go and access the help they need. Another way to do it is face-to-face, or what they call CBT group workshops. And in a group setting, it's a face-to-face setting, and then you have many people, a few people coming together, not so many, and the therapy is offered like a group workshop. They also provide access for peer support, a sense of belonging, building relationship, and then like building a support system for them towards their recovery. The psychological well-being practitioners will offer 6 weeks therapy using the non-directive counseling or person-centered counseling, or the CBT technique to provide the therapy. And then let's look at the step 3. In step 3, you're looking at moderate to severe, and it's what we describe as higher intensity. They are CBT practitioners. Some of them they are practitioners in EMDR, rapid eye movement desensitization and reprogramming. And then, of course, they also offer the CFT, the compassionate focus therapy group. How do they become step 3 CBT practitioners? They first of all need to have a degree. It could be a degree in social work. They could be mental health nurses, or they could be psychologists who used to practice as psychological well-being practitioner, and they want to increase what they offer and their skills and competency. They now have to go back to the university to study to get this diploma to become CBT practitioners or provide a high intensity counseling. It's a 1-year diploma in CBT therapy. They can have degree in social work, and they offer or degree in psychology or mental health nurses, or they might have to provide an evidence, like a portfolio of evidence, to say that they have the skills and competency to step up to the next level. And they offer 12 sessions or more. And of course, in the 12 session, there you have what we call the mental health practitioners that work with them to prepare mothers for therapy. So if a mother is struggling with housing, is struggling with money, the mental health practitioners will work with them to deal with, the little things that might prevent them from accessing therapy. If it's a mother that is living through domestic abuse, of course, they can work with them to find access to help and support so that they can be in the right frame of mind to access this support or this therapy. And then, of course, we think about the general practitioners or the GPs, the doctors. The GPs By the Royal College of General Practitioners in the United Kingdom, they are expected to do maternal mental health assessment when they see mothers for their 6 weeks postnatal check. They will do maternal mental health assessment using Edinburgh Postnatal Depression Scale or PHQ-9 GAT-7, and they will use their clinical skills asking questions to assess the mental health of these mothers. And of course, the GPs will prescribe the medications like the SSRIs. They will prescribe the medications like anxiolytics, sedatives to help mothers when they are dealing with mild to moderate mental health illness. I just want to think about the integration, because it's not just each person working on their own. Everything is integrated together. The way I work as a health visitor, I work with the GPs. I have direct link with the psychological well-being practitioners. I have direct link with the step 3 CBT practitioners. When I refer a mother to them, they will give me updates of what is happening. I co-facilitate the compassionate focus therapy group that they run. So it is everybody working together seamlessly. The same thing happens if the mothers are referred to the step 4, where you have the psychiatrist and where you have the occupational therapists and the social workers working with mothers in an inpatient unit or the outpatient unit, the home treatment team. They know who the health visitor of the family is. They work alongside us and they give feedback. Sometimes you have to do joint visit with them so that these mothers can, and the babies and the family can access the care they need when they need it. I just want to talk about the role of the voluntary sectors, because I have talked about mainly the NHS practitioners. There are voluntary sectors that are offering mental health care as well to families, to mothers. I want to talk about a voluntary sector called Mom Matters. It's in Manchester. These are not like clinicians, but these are people who have passion. They have interest. It is part of Manchester Mind, or what they call Mind in the UK. Mind is a charity. So they offer 8-week course designed to support new mothers in Manchester with children under the age of 2 who are experiencing mental health illness. What do they do in the 8-week course? It's an opportunity for these mothers to collect meaningful well-being tools that they can use to manage their mental health, to support their mind, to help them to feel better. They also offer what they call prompts to support mothers. It's opportunity for nurturing self-confidence, self-esteem, well-being, opportunities for mothers to think about themselves. We know that when mothers have babies, suddenly for a lot of mothers, everything about themselves disappears. It's about the baby, the family, the husband, the mother, the baby, the family. Everybody else has a priority apart from that mom. Hence, the mom will wake up in the morning and work till dawn. She will look after the family all day, and then the night she's the one looking after that baby, feeding. So what the Manchester Mind or Mom Matter does is to do this 8 weeks course with these mothers in a group setting, where initially there will be a check-in. They will check in, how has your week been? And they will do like some relaxation exercise, some breathing technique at the beginning. And they will now begin to thinking about looking after yourself, basic self-care, hydration, diet, eating, medication. And what they also do, they work alongside other practitioners. So if a mom is accessing psychological well-being practitioner service or CBT therapy, they work alongside Mom Matters. So Mom Matters would, if the mom tells her that she has a psychological well-being practitioner, the person offering the group can contact the psychological well-being practitioner and support these moms to access the care. And they also have quite a lot of work looking at how to challenge negative thinking and negative thoughts in their group session. They look at wellness action plan. And when they come in the next week, they think of the wellness action plan, how it been. They do a lot of checking. And the good thing about this is there's a provision for the care for the baby. So there's a creche alongside, running alongside, where mothers can leave their baby to be able to just have that time with fellow mothers to access this therapy. Moms get to connect with other mothers. They build themselves a little network, a social network, whereby they can go out and do other things. They can go out, and do other things, go for a walk in the park. They can do other things apart from, just the basic routine of a mom's life. And then, of course, they're supported to keep what they call a thought diary. So when the thoughts come, they can think about it, they can pull that thoughts to the surface, and they will be able to deal with that thought. And we know what some of the negative thoughts can be. The thoughts can be, you're not good enough, you don't even know what you're doing. And if that mother is living in an environment where everybody's talking down at them, they tend to believe that that is what they are. So in effect, the system we work with is a system that tries to look at all aspects of the predisposing factor, the multiplicity of the factor that can predispose to mental health illnesses or exacerbate mental health illness, and also looking at a system for assessing a system. And then when they are assessed, if an assessment of mental health becomes a universal provision, that everybody knows that the other mother was asked about it. So I am not the only one being asked about it. So the stigma becomes much reduced. Because in many cultures, especially when we're thinking about some of the ethnic minority group, it is still a problem when we're thinking about mental health issues. So we work with the local community groups. There is the charity organization working alongside, and then of course the mental health practitioners working with the NHS, everybody working in an integrated, seamless form to provide mental health care. And while we're doing that, the babies are not left behind. We have the early attachment service, the parent-infant relationship service, working with that mom to build a relationship with her baby. Thank you very much.
Thank you so much, Anulika. So much of food for thought, and I must say we're just a bit envious, I'm sure, with people on this group in terms of the ideal almost, or close to ideal, of a multidisciplinary team. So thank you for highlighting that there are a number of cogs that fit together that allow us to look after the family, not just specialists, but basically across the board. And I like also the idea of the volunteer services. Anulika, I have a few questions I'm not going to ask because there are some questions in the chat. If you can open it up there, you can address that. But I want to ask something first, and then I will move on to the Q&A, and then there is one in the chat room from Rosemar. Anulika, the idea kind of in my head is, how acceptable are these home visitors in diverse communities? So there's, we have a lot of conversations that we have obviously locally in our service and in very limited resource settings. And we know that the stigma against accessing care, safe care, in whatever form for mothers who are struggling in the perinatal period is really clouded by a lot of stigma, and the idea that it's actually not accepted, or it's a very westernized idea of it, or the intrusiveness of someone coming in and telling you how you should or shouldn't manage your family, something that's been happening for generations. So I think it might be quite interesting if you'd give us maybe a short answer, an overview of what happens in diverse settings. So if we're looking at, and I see it leads on to Buzil Wayo's question about refugees, migrants, people of color, minority groups in the UK, but actually quite reflective of our settings where, this is not standard to come in and answer tick boxes. So maybe if you just give us a sense of what that's like.
Yeah, I think the problem is real. It's not just in South Africa, or in other parts of the world. It is quite intrusive to come into people's house. And sometimes when families see you and they don't know who you are, they might think that you're a social worker that's coming to catch them out, coming to find out whether their house is clean or not clean. But again, the practitioners are trained, highly trained, to build relationship. Building relationship is the way forward. And it's not about going to tell people what to do. It's building an alliance with the people and looking at strength-based approach. How do you support families to access care without being judgmental, without being critical? That is one. And then the other thing is, everybody that comes into the UK will go and register with the general practitioner, will go and register with the GP, because the GP provision is just the baseline access where where you get your care. We are, so far, like in other parts of the world, you will have your doctor where you go to access your care. Every GP will link the family to the health visitor. They would say to the family, like, your health visitor will come and see you. So, for example, if the mother is accessing her care in a maternity center or a doctor, a private doctor, if every healthcare provision has a system in place for letting people know that the public health nurse, the health visitor, will come to see you, they will look at the developmental review of your baby, they will support you around integrating into United Kingdom. That doesn't mean that it takes away the stigma. The stigma is still real, but you're just chipping away, you're being there. And then the next step is working with the community groups. Because when we are able to get the community group to come on side, like the churches, the pastors, the priests, the mosque, the imam in the mosque, the leader in the Sikh temple, and they know that mental health problem is real. And it's part of what the NHS or what the community, the voluntary groups will support families towards. They will let the families know. They will support the families to access the care.
I think that's such an important, I think that's such an important thing, because I think for people on the group, it's often, again, something we dabble with about community participation. And it is really such an integrated service in order for us to address that stigma, but also to make people feel less threatened. And I think maybe that speaks to the question here, which is really asking about data showing that refugees and migrant women who come from war-torn countries have a very high risk of maternal mental health issues. We know that. And she's asking, what is the procedure in circumstances where families don't trust or refuse the health intervention? And she's asking because obviously the risk to the babies. And I think you kind of partially alluded to that, but maybe just to wrap that up, if you wouldn't mind saying, if they refuse it and you are worried about high flags, does the healthcare visitor then sort of suggest or report or strongly encourage? I mean, what is your statutory obligation there? Speaking to
Thank you so much. I think the statutory obligation is to go and see them. And if they refuse, you cannot force yourself into the house. However, when they come out to the GP, when they go to access other care, they will ask them, has your health visitor seen you? And then when we now gain access, and then we do the maternal mental health assessment and we flag some of these needs, it is obvious that some people might not want to access the care. Hence, we have a tiered level of support. So you have charities, including peer support workers. They're just voluntary sectors. Some of them, they are commissioned by the NHS, they are paid by the local, many of them are paid by the local authorities, some of them are paid by the NHS, and some have just peer support workers who are not paid, they're just giving their transport. And some will need a hand-holding. They will need somebody to hand-hold them into that first clinic, to hand-hold them into that first appointment, because it is daunting. And mental health, as real as it is, people will kind of align themselves to what they see. But mental health is quite internal. It's about the mind. So they might be telling you they're still functioning, but you can look at them, they're functioning, but they're struggling to function. That is at that early level. But then if it becomes the person becomes really unwell, then it dips to step 4. And of course, that is where you now have a different level of intervention, including the police, including, the people can be sectioned. Of course, I don't know what they can be sectioned, they can be admitted into the hospital against their will to be treated if they become very unwell. But the main thing is trying to prevent people from becoming very unwell. So you have a lot of these systems in place whereby we're not waiting for the person to become really unwell. The voluntary sectors are trained. You have psychological well-being practitioners, you have health visitors, and we have what we call integrated pathway. So my pathway for health visiting is linked to the psychological well-being pathway, and that is linked to the GP pathway. It is linked to the psychiatrist and the mental health trust. All the pathways are linked together so that wherever we need help, we can lean towards that for the family.
Thank you. That is very helpful, I think, for two reasons. One is that it's reminding us that when we're thinking of designing services, it is about not dealing with things in isolation and in silos, but really the integration, and that the one system must feed into the other if we are really going to provide this model of integrated care. And it works better when there is that buy-in from everyone. And I think actually you've answered the next question. Craig, I see your question, but I just want to jump ahead because I think you've answered what Charles Ume is asking, which is saying, thank you for the presentation. Would like to know how postpartum psychosis could be managed. And you've just addressed that it goes into the level 4, which in other countries are sectioned, which means involuntary care and care which is relative to risk. And so I would imagine that means accessing a healthcare practitioner that can either provide medication or admission or inpatient services. That's the different level of it. So Craig, do you want to go ahead and ask your own question? I don't mind if you do that. Go ahead.
Okay, yeah, happy to do that. And it's good to be here, and I really enjoyed the presentation. I'm interested to understand, do you see any progress in the use of smartphones as a means of ethical, continuous screening and assessment, and of course, with the permission of the citizens that would be using it?
At the moment, there is what we call the new TOPO reports or TOFO reports.
Yeah.
So the digital healthcare coming into United Kingdom, the vision for the new NHS, pushing for the digital world. And at the present, there's a lot of research going into it. I am a co-investigator for a current research. It is called the DOMP research. The DOMP research is looking at digital assessment for the well-being of mothers. And what we did is to get the NIHR, the National Institute of Health Research and Care, funding to develop this app. And in the app, it's got the mental health question using the Edinburgh postnatal depression scales, and mothers are self-assessing, self-monitoring. And then, of course, the reports are fed back every day, and then it's the research officers look at the results. And then the results are also linked to the healthcare. So it's not just, we're not just doing the research in silo. It is fed back to the GP, it's fed back to the health visitor. If a mother's school becomes, the trigger for a mild to moderate or severe mental health problem, of course, he goes straight. And that's to the health visitor, to the GP. And then, of course, there is a trigger for admission into the hospital or access to emergency care. So there are a lot of research going on. It's not just the DOMP research. The DOMP research is the one that I'm one of the co-investigators, and we're hoping it's just at the phase of the feasibility study. We have about 75 mothers in this study at the moment. And after the feasibility study, it's not going to now going to step into the bigger study for it. It's been ongoing now for a year and a half, and the study will be finished by the end of this year. Our first publication on DOMP study will be coming out very soon. And while we're doing the DOMP study, there's other studies around use of the digital world for assessing mental health. And also interventions.
All right, thank you for that. I'll be following that with interest. I hope you don't mind if I follow up with you from time to time about how that's going. Thank you.
That's good. That's fine.
All right.
I'll let you know. Good.
Craig, you also asked if there was a document available that explains...
Yeah, that's really, request for references is what the other two questions were.
Right. So, Anulika, if you wouldn't mind a request for references to this program, to the health visiting site, maybe we can also then share it with all the participants on this call so they can have it. I'm wondering if there's any other questions. We're almost done. if anyone can raise their hands. I have a final question, just a thought. I mean, I hear you talk about the GPs and the referrals and going up into the healthcare sector. One of the big barriers to clinical service delivery really is about awareness of other healthcare practitioners in terms of what is needed, what constitutes perinatal mental health, when you need to intervene, and when medication is, for example, necessary. And one of the major stumbling blocks we experience as clinicians locally is really no buy-in from the antenatal service, which is usually gynecologists, antenatal nurses, who have a very high threshold before they're going to refer someone, before they're going to think, actually, you know what, this is not just baby blues, this is really something we need to. I'm just wondering if that is the case in the UK, and if there is space within the obstetrics and gynecology training, like you've mentioned, there's training in social work and in GPs as part of it, and obviously in psychiatry. Even in psychiatry, as I understand it, the training is quite focused on if you branch out into perinatal medicine, but actually in general psychiatry is not great. I'm just wondering what your thoughts are on that.
In the UK, both the obstetricians and the gynecologists, everybody is in that perinatal period is expected to sign into the NHS mental health long-term plan. So it's an integrated approach. So we have midwives who are called specialist midwives for perinatal mental health. And at booking, when they come to book for antenatal care, mental health assessment is part of the assessment at booking. It's not just about physiological well-being of that mother and checking if the baby is growing. There's a lot of mental health assessment pretty much at every contact. Well, at booking is where they do the mental health assessment, and then, of course, following the delivery, and they will send to the harvester what we call the MEF, which is mental health assessment and care plan. So the care plan for that mother might mean something like, please, can the harvester see this mom very soon after she comes home because of her mental health? The care plan could mean, when this mom has a baby, please, could she be in a quiet room away from disturbance because of her mental health? So these are the care plans the obstetricians and the midwives will put in place for the mental health. So I think because of the integrated approach to it and this big drive to shift away from just thinking about physiological illness, everybody is kind of getting the buy-in. Everybody is encouraged to get the buy-in. And when we think of maternal mental health being the leading cause of death in the perinatal period, of course, people will get more interested. Previously, for the obstetrician, one of the leading causes of death would be something like preeclampsia and eclampsia. And then it started shifting in the Western world. And we're looking at suicide as one of the leading causes of death. Then, of course, people will get more interested because you want the mothers to be well. So we, at the moment, I believe that we have the buy-in, and definitely across the UK, we have the buy-in of the obstetricians. And a lot of them have become champions in perinatal mental health as well.
Fantastic. So we'll take one last question. Charles, go ahead. Unmute yourself and go ahead.
Okay, thank you very much for this program. I listened attentively and something caught my attention. This program, as they're carried out in UK, has a lot of hope. But I don't think we have something similar in Nigeria. In fact, mental health is not an issue they discuss in ONG.
Yeah.
But until they come down with either postpartum depression or postpartum psychosis. How are we going to motivate ONG people in Nigeria to incorporate this, seeing that it is really important in the well-being of every nursing mother?
Thank you very much, Charles. Thanks for your question. The way forward is a system-wide approach, very system-wide approach. When we get the buy-in of the policymakers, we begin to shift things. The politicians, the people that make the policies in the nation. And then the other thing is education. When we begin to educate people around the mental health, the effect. And when we're looking at mild to moderate, I'm just sitting at mild to moderate because that's where a large population of people sit. It's only fewer people like Charles, that have dipped up to postpartum psychosis and psychotic illnesses. But a lot of people are just on that level of mild to moderate, just barely managing to function. And people think, oh, she's tired, oh, she's just being lazy. So re-educating the population, when you re-educate the population, you give them like a sense of empowerment to say, do you know what? I don't think I'm lazy. I think I feel unwell here. I'm actually seeing things very negative. There's a lot of self-blame. There's a lot of self-criticism. I run into conclusion very quickly. And these are the things that we have to bring into the training for the obstetricians. If we put it into the educational system, to the university educational system, people will listen. If we get the regulatory body of Nigeria that regulates the obstetricians for them to qualify to become specialists, to build into the training program mental health for mothers, they will listen.
Thank you, Charles, and thank you, Anulika. What a lovely way to
Thank you very
end.
much.
I think I want to just say to everyone that that's exactly the kind of thing we should be doing, which is speaking to policymakers, but also representing in spaces where maternal mental health is not commonly talked about.
Yes,
So that's the way we kind of expand the reach, and even if that means to the lay public, where we're psychoeducating, that already is a first step, and not just targeting at professionals all the time. So with that, I want to say, Anulika, thank you so much. That was fantastic. And what a great idea and example of a work in action, which really straddles so many parts of what we're aiming to achieve and wanting to build up across the continent, which is really in terms of education, advocacy, clinical service in action, and walking the talk. So I really appreciate that. We're very grateful for your time. And for accommodating us. And to everyone who has joined us, thank you very much. We're aware that there were many people who were not able to join us, unfortunately, because of the power outages and the internet, but we will be sending this recording to everybody. And just a reminder to everyone who's attended, you will, after this, get a survey. If you wouldn't mind completing it, will take you under a minute to just give us some feedback, and because we're trying to re-establish a kind of clinical connecting and interactive forum. So Anulika, thank you again on behalf of the AGMHI and myself, and for really holding that flag high for maternal and infant mental health. Thank you, everybody.
Thank you.
And we really appreciate everyone's attendance.